চন্দ্রকান্ত না না ওকে দিয়েছিল কে ছিল ছেলেটা হ্যাঁ এটা হ্যাঁ
Good evening. Good evening.
এটাই হবে হ্যাঁ এটাই
It's my great pleasure to welcome Dr. M.V. Chandrakant, medical oncologist at Narayana Super Specialty Hospital. He's going to talk to us about bone health in prostate cancer. Dr. Chandrakant. I'm afraid there are great problems with the PowerPoint presentation. So Dr. Chandrakant is going to present extempore.
Okay. So I'm sorry for the technical glitch, So after changing the laptop, there is some lane problem and they're not able to project the slides. So I will take this opportunity to present verbally whatever I know and whatever I have experienced as far as the bone modifying agents in prostate cancer is concerned. So I am Dr. M.V. Chandrakant. I'm a medical.
Perhaps we can take it as a question-answer format. I
Yes,
mean, you
yeah.
can present a bit, and we can ask you.
Sure,
we can
sir.
discuss.
Sure,
Okay.
sir. Sure. I think that's better than having a monotonous slide presentation. I think that's a good idea, sir. So so today we will discuss on what are these bone modifying agents we have in practice and how important are these and where we can place these bone modifying agents in our clinical practice. So the moment we say of prostate cancer, if it is a non-metastatic prostate cancer, it's a loco-regional disease, it's completely your territory. We hardly have any role as of now, except in very small subset where we do offer some systemic therapy. So the moment there is bone metastasis in a prostate cancer, we have something called as a hormone sensitive phase, and then we have a castrate resistant phase. So in a castrate sensitive or a hormone sensitive prostate cancer in a metastatic disease, the initial 1.5, 2 years is the hormone sensitive period where there are multiple bone mets. So the usual rule of thumb in oncology or any other cancer is the moment there is bone metastasis, we should give bone modifying agents because there is a higher risk of skeletal related events. The skeletal related events, what we name are pathological fractures, requirement of radiation, requirement of surgery, hypercalcemia, cord compression. So these are the skeletal related events that we consider. So in a hormone sensitive patient, there is always a tendency to give a bone modifying agent in clinical practice. But very importantly, what we need to remember in a prostate cancer is these bone mets are osteoblastic mets. And giving bone modifying agents in this situation is probably not helpful. And this has been addressed in a Stampede trial where zoldonic acid versus no zoldonic acid has been compared, and there is no difference in skeletal related events. So therefore, in a hormone sensitive phase, we usually do not give bone modifying agents in clinical practice. So therefore, all the guidelines recommend against using bone modifying agents in the hormone sensitive setting. And we reserve bone modifying agents only for the castrate resistant phase. So any thoughts on that, sir?
Okay. Now I have a very simple question for you. A man with prostate cancer who does not have bony metastasis or say has biochemical recurrence after early radical treatment, and he's now prescribed androgen deprivation therapy. So what are the risks to his bone in the long term, and how can we prevent that?
Yes. So the moment we are knocking out testosterone, so he is under what is called androgen deprivation. So androgen deprivation, age, and steroids, if we give along with that, all these contribute to osteoporosis. So this causes loss of bone mineral density. And of course, this patient is at risk for developing a SRE. So in these situations, ideally we must do a DEXA scan and look for the bone mineral density, whether it is minus 2.5 or minus 1 to minus 2.5, and accordingly we should plan. So in these situations, we are going to give bone modifying agents, but our intention is prophylactic, preventing SRE, and the dose becomes once in 6 months, not once a month or once in 28 days. So the dose changes.
So, you know, we are urologists. A patient comes to us in the clinic with this, I want to prescribe him ADT. So do I go for a FRAX score and that sort of thing, or should I check his calcium and bone health, vitamin D3? Should we prescribe oral calcium,
so
oral vitamin D3? In
correct.
what form? And how
Correct.
do these things, you know, these are the questions. You know, guidelines change, and that's why we
Correct.
ask.
So when there is no bone metastasis, then we have to understand the bone mineral density. So we can understand that objectively by doing a DEXA scan. If there is no facility or no prospect for doing a DEXA scan, as Sir was saying, FRAX score is of course an indirect reflection of what is the fracture risk in this particular patient. And along with this, of course, we have to supplement calcium and vitamin D as per the deficiency. And we can add, and we should add bone modifying agents once in 6 monthly doses to prevent the development of fracture. The dose is not once monthly, it is once in 6 months. And I agree, we must have a calcium and a vitamin D supplementation for all these patients. And here it is once in 6 monthly. So this is the dose that we usually use in a non-metastatic setting.
And would you use the chelating agents at all? I mean, oral chelating, oral Zolidron?
Oral, yeah, we can use, there is alendronic acid, pamendronic acid. So there has been a meta-analysis comparing all these. So there is no superiority of one over the other. But somehow in the metastatic setting, zoledronic acid has come up as the most efficacious bisphosphonate among all the existing bone modifying agents. So zoledronic acid is cheaper and it is once in 6 months, and that is what we usually use in clinical practice. And the moment there is some renal derangement or any previous reaction to sort of flu-like reaction to zoledronic acid in these patients, and where there is an IV cannulation difficulty, the patient is not accepting, and there is a luxury of reimbursement. In these patients, we can use subcutaneous formulation of denosumab, again at osteoporotic doses in the non-metastatic setting.
Right. You have done a scan, you have found that the patient has osteoporosis. Would the presence of an osteoporosis dictate the type of ADT which you are giving? So the indirect question being, is any agent better or castration better?
Okay, so there is no such, the ADT is given to knock down the testosterone levels. So there is no such ADT that is helpful for bone as such. We want the testosterone levels to be at castrate levels. That is what I understand. So regarding the androgen, the androgen blockers, so of course we have to use the strongest androgen blockers whenever feasible. So I don't have any preference of ADT for bone health as such.
So if you go through the NCCN guidelines, it has been in the older guidelines, I believe 2019. So there is a mention that castration, surgical castration for bone health per se is better than LHRH agonist as well as antagonist. I believe the target of getting the testosterone low is achieved by either of those. But for bone health, I believe castration has a slightly upper edge over the...
Correct. So there was a comparison of intermittent androgen deprivation therapy versus continuous androgen deprivation for bone health, and definitely having an intermittent androgen deprivation was better for bone health. But this did affect the PSA, PFS and the overall PFS. Therefore, intermittent androgen deprivation therapy is not the standard of care in the metastatic setting, at least as of now. Okay.
So in practice, we actually have not seen a lot of fractures in these patients. So maybe actually as, as the aging population, I think these fracture risks are important. possible.
Agreed, sir. Agreed.
The other question I have, and may I ask anyone in the audience who has any questions to ask him as an expert, is there any evidence that using zoledronic acid or this type of bone-directed therapy, does it prolong life in metastatic prostate cancer patients?
So, excellent question, sir. So, we use bone-modifying agents for different purposes. Number one, does it improve life to the patient? Number two, does it reduce pain? Is there a symptomatic benefit? Number three, does it reduce skeletal-related events? These are the three questions which we usually answer. So, in metastatic breast cancer, we have evidence where if you use zoledronic acid, the hazard ratio for overall survival has improved in a HR-positive breast cancer. But as such, these bone-modifying agents have no direct effect in prostate cancer metastatic in terms of overall survival. However, quality of life has been addressed, SRE has been addressed. Both are better with bone-modifying agents.
So we often use a term called impending fracture or an impending spinal cord compression. So describe that. I mean, we do not ever offer an MRI to a patient. Then how do we know clinically that this is a case which might have going for an impending fracture? And what is your management for patients having bone pain?
So bone pain is definitely one of the most painful scenarios, and it has to be dealt with urgency. So the moment there is bone pain, the first priority is analgesia. So for analgesia, zoledronic acid is as effective as palliative radiotherapy in terms of analgesia. There have been a comparison, and the magnitude of analgesia with zoledronic acid is equivalent to a palliative radiotherapy. So the moment if it is hormone sensitive setting, ADT will take care of the bone pain. The most effective management of symptoms is an androgen deprivation upfront. And then comes a bone modifying agent if it is in the castrate resistant setting. And then comes NSAIDs or paracetamol as per the stepladder fashion. And then we will add opioids, and a bit of dexamethasone also are helpful in bone modifying agent. And we will also keep palliative radiotherapy for the next resort. And systemic therapy is of course there to handle the disease part of the bone.
Is there any question from the audience regarding prostate cancer and bone pain? If not, Gopal, yes.
I think the first thing is that your extempore lecture, in the absence of slides, reminds me of a lecture by Professor Tony Mundy a few years ago at a UCCon, where his slides suddenly went away because of power cut, and then he started speaking extempore. So it brings back some old memories. It just shows the depth of knowledge that you have on the subject. Congratulations.
Thank you.
The second thing is, it's interesting to know that as long as the cancer is in hormone sensitive phase, the need for bone strengthening is probably not so acute as it comes to the hormone resistant phase. So that is something new for us. I am still not completely clear about why you feel that bone strengthening is not so much required during the hormone sensitive phase, because androgen deprivation itself causes osteoporosis.
It is required to take care of the osteoporosis, but not of metastasis.
Not of metastasis. Okay, all right.
Okay.
So then the final words I have to speak on the comparison of denosumab versus zoledronic acid, for which I am here. So there has been a randomized trial specifically addressing the CRPC setting, comparing this big randomized trial of 1,000 odd patients, comparing head to head with denosumab versus zoledronic acid. And when they have compared, they have used the primary endpoint as skeletal related events. And definitely there is a delay in the development of first skeletal related events, followed by development of subsequent skeletal related events. Therefore, but the overall survival has been the same. So definitely if there is a feasibility, we must use denosumab over zoledronic acid if you have SRE as your endpoint. And they have also looked into the quality of life parameters and the fever that they feel with zoledronic acid. It is better with denosumab when compared to zoledronic acid. And creatinine clearance is one issue because they have obstructive uropathy and some renal dysfunction. in these situations, again, denosumab scores over and above zoldonic acid. And if you look into the side effect profile of denosumab versus zoldonic acid, osteonecrosis of jaw is little more, hypocalcemia is little more with denosumab when compared to zoldonic acid. And they have also analyzed whether ONJ is so worse that we should stop using denosumab. So they have taken multiple parameters of efficacy, benefit versus ONJ, and they feel that a little bit of increase in ONJ cannot be argued that we should avoid denosumab. The amount of ONJ is so low that probably the benefit of SRE supersedes the side effect of osteonecrosis of jaw. So therefore, whenever feasible, we must use denosumab in practice if cost is not an issue. And there are a few more trials in oncology where they have compared 12 weekly, once in 3 months zoldonic acid versus once monthly zoldonic acid, and they have shown equivalence. But this sort of equivalence is yet to happen in denosumab. So denosumab is even now is once monthly only. And if it is zoldonic acid, once in 12 weeks versus once monthly has been compared, probably they are equivalent.
Okay, and one final question before we proceed to the next session is that, you know, as general urologists, we know that there are 2 bone-directed treatments on the horizon. One is already here, which is the lutetium PSMA therapy, which, and the other is this radium-223 therapies. Now, previously for crippling bone pains and metastatic castration-resistant prostate cancer, we were using strontium-89 and then pamidronic, whatever, P30 phosphorus preparation. What is your take? Where do these things fit into the spectrum of options in prostate cancer?
So perfectly, sir. If you look into the efficacy of anti-cancer therapy in prostate cancer, ADT is the best anti-cancer therapy ever known in prostate cancer. After that, we have got some molecules like docetaxel, and then we have abiraterone, which is as good as docetaxel in the hormone-sensitive setting. And then we have enzalutamide, and then cabazitaxel. This is all what we have in prostate cancer. And now we have some PARP inhibitors coming in, that too in a very select subgroup patients if it is positive in CRPC setting. Apart from that, Sipuleucel T was there, which is just read and never heard of and never seen. So we have evolution of, as you said, strontium therapy, samarium therapy, actinium therapy, and lutetium therapy. All these have good results, and the endpoints are all quality of life and PFS. But radium therapy is the only treatment which has shown an overall survival difference. So whenever feasible, if someone asks me in the clinic, what is the best treatment available as far as the radioactive therapy is concerned, I always say radium as per theory, and because it has shown an overall survival benefit. So definitely in terms of bone pains, in terms of progression-free PSA, PFS, these are good. So somehow the talk is, if radium is not available, then probably actinium sort of is probably good. In Mumbai it is there, and lutetium is also good. So these are the things which we usually offer, and we have seen patients doing well for a bit of time and with good symptomatic treatment.
They will relieve pain.
Relieve pain, PSA, PFS, but overall survival, there is no data.
Okay. Okay, thank you actually. Do you have any other questions, General?
Nothing, let's start.
Okay.
Thank you so much.
Thank you very much indeed actually for,
thank you.
I think this was useful knowledge for all of us. Thank you.
Thank you. Thank you, sir. Thanks, everyone.